my name is Gianna and I'm from Kaiser University, and today I'm going to be talking to you about AP foot, oblique foot, lateral foot, AP weight bearing, and lateral weight bearing, and what technical factors are being used, what positioning is used, the anatomy shown, and the clinical indications. Video teaching presentation, The Foot, by Gianna F. Peralta. AP foot. This is an x-ray of a left AP foot. On the right, you'll see an AP foot part positioning projection. The AP foot projection. Patient position. Patient is supine, and you can give a pillow for the head. Part position. Knee is flexed. Plantar surface is on IR. Sandbag can be used to immobilize the IR if needed. The opposite knee is flexed or extended. CR is perpendicular to IR. CR is directed towards the base of the third metatarsal. Collimate on 4 sides to area of interest. The entire foot should be demonstrated, included all phalanges and metatarsals, and the navicular, cuneiforms, and cuboids. The AP oblique projection of the foot. This is an AP oblique foot x-ray. This is an AP oblique foot projection. The AP oblique projection of the foot. Patient position. Patient is supine or seated. Part position. The knee is flexed. Plantar surface is on IR. The foot is rotated 45 degrees medially. A wedge can be used to support the foot and prevent motion. If necessary, turn body slightly away from one side in question. CR is perpendicular to IR. CR is directed to base of third metatarsal. Collimate on 4 sides of interest. The entire foot demonstrated, you can see the distal phalanges to posterior calcaneus and proximal talus, the interphalangeal joints, the head of the metatarsals, shaft of the metatarsals, the cuneiform, the navicular, cuboid, and talus. Medial lateral projection of the foot. This is a medial lateral foot x-ray. This is a medial lateral foot projection. Patient position of the medial lateral projection of the foot. Patient is in lateral recumbent. Knee is flexed 45 degrees. Foot is carefully dorsiflexed for a true lateral position. Support under leg and knee if necessary. CR is perpendicular to IR. CR is directed to medial cuneiform at level of base of the third metatarsal. Collimate on 4 sides to area of interest. The entire foot should be demonstrated, and a minimum of 1 inch of the distal tip fib metatarsals will be nearly superimposed, with only the tuberosity of the 5th metatarsals shown in profile. The AP weight-bearing foot. This is an AP weight-bearing foot x-ray. This is an AP weight-bearing foot projection. The AP weight-bearing foot. Patient position. The patient should be standing erect, full weight evenly distributed on both feet. Feet should be parallel to each other. CR is angled 15 degrees posteriorly to midpoint between feet at level of base of metatarsals. Collimate to outer skin margins of the feet. The anatomy demonstrated shows bilateral feet from soft tissue surrounding phalanges to the distal portion of the talus. The lateral weight-bearing projection of the foot. The lateral weight-bearing foot x-ray. This is a lateral weight-bearing foot projection. The lateral weight-bearing projection of the foot. Patient position. Patient is standing erect with weight placed on affected foot. Patient stands on wood blocks placed on a step stool or the foot rest attached to the table. You can provide support for patient to hold on to the table if needed. The CR is horizontally to the level of base of the third metatarsals. Collimate to margins of the feet. Anatomy demonstrated is of the entire foot should be demonstrated along with a minimum 1 inch of distal tip fib. Distal fibula should be superimposed over posterior half of the tibia, and plantar surfaces of heads of metatarsals should also be superimposed if no rotation is present. My references. I got most of my references from the Bontrager's Handbook of Radiographic Positioning and Techniques, 9th edition, by John P. Lampigano and Leslie E. Kendrick. I also got a lot of my images and some of my information from radiopedia.org/articles/foot series. Technical factors and clinical indications. Technical factors used for foot projections range from 50 to 60 kVp and 1 to 2 mass. Clinical indications to why any of these procedures might be done are the following: foot trauma, bone tenderness in foot at the base of the 5th metatarsal, inability to weight bear more than 4 steps, non-traumatic foot pain, suspicion of fracture. Thank you for listening to my video and viewing my PowerPoint, speaking about AP foot, oblique foot, lateral weight bearing, and AP weight bearing, and what anatomy is shown, the technical factors used, clinical indications, and positioning shown. Thank you.